The prevailing narrative regarding pelvic health in the aging population has long been dominated by a singular, often oversimplified directive: perform Kegels. For decades, the medical community and fitness industries have propagated the idea that the solution to urinary incontinence, pelvic organ prolapse, and general core instability lies solely in the repeated isolation and contraction of the pelvic floor muscles. However, as our understanding of biomechanics, facial systems, and functional anatomy has evolved, it has become increasingly clear that this isolationist approach is not only insufficient but, in many cases, mechanically flawed, particularly for the senior demographic. To truly understand how to prevent urinary incontinence and restore structural integrity to the pelvic girdle without relying on the repetitive squeezing of Kegels, we must first deconstruct the functional reality of the human body, viewing the pelvic floor not as a hammock suspended in isolation, but as a dynamic, reactive component of a much larger, integrated kinetic chain. The pelvic floor does not function in a vacuum. It is the floor of the core canister, working in perfect synergy with the diaphragm above, the transverse abdominis in the front, and the multifidus muscles along the spine. When we treat the pelvic floor as a solitary muscle group to be trained like a bicep, we ignore the complex interplay of intra-abdominal pressure and load management that actually dictates continence during daily activities. For the aging adult, the concept of urinary incontinence is often falsely attributed solely to muscle weakness. The assumption is that the muscles have simply atrophied and become hypotonic or loose, and therefore require tightening. While muscle atrophy is a natural component of sarcopenia, the age-related loss of muscle mass, the reality of incontinence is frequently rooted in dysfunction rather than mere weakness. In many seniors, the pelvic floor is not too loose. It is actually hypertonic or too tight, locked in a state of chronic, low-grade tension that renders it unable to react to sudden increases in pressure, such as a cough, a sneeze, or the act of standing up from a chair. A muscle that is constantly contracted is a weak muscle because it has lost its range of motion. It cannot lengthen to absorb force, nor can it contract further to close the sphincters effectively when needed. This is why the traditional prescription of Kegels often fails or exacerbates the problem. Adding more tension to an already rigid, non-pliable system does not restore function. True continence requires a pelvic floor that is resilient, capable of lengthening eccentrically to accept the weight of the viscera and contracting concentrically to maintain closure, all while coordinating subconsciously with the breath and the movement of the hips. This brings us to the critical anatomical connection that forms the basis of the exercises we will explore: the intimate relationship between the pelvic floor and the muscles of the hip complex, specifically the obturator internus, the gluteus maximus, and the hip adductors. The obturator internus is a deep hip rotator muscle that lines the inside of the pelvic wall. Its fascia is continuous with the levator ani, the primary muscle group of the pelvic floor. This facial connection means that when you activate the deep rotators of the hip, you invariably influence the tension and function of the pelvic floor. It is a biomechanical impossibility to separate the function of the hips from the function of the pelvic floor. Therefore, the most effective way to strengthen the pelvic floor is not to squeeze it directly, but to load the hips through functional movement patterns. When a senior performs a movement that engages the glutes and external rotators, the pelvic floor is naturally recruited to stabilize the bottom of the pelvis. This indirect recruitment is often more effective than a voluntary Kegel because it taps into the autonomic reflexes of the body, training the pelvic floor to fire in reaction to movement, which is exactly what is required to prevent incontinence during real-world activities. Furthermore, we must consider the role of the adductors, the inner thigh muscles. The adductor magnus, in particular, has a mechanical advantage in stabilizing the pelvis and works synergistically with the pelvic floor. In many cases of stress incontinence, there is a distinct imbalance between the adductors and the abductors, leading to instability at the pubic symphysis. By strengthening the inner thighs in a functional manner, we provide a lateral buttress of support for the pelvic organs. This structural support is vital because the bladder sits directly behind the pubic bone. If the muscular sling supporting this area is imbalanced due to hip weakness, the bladder neck becomes hypermobile, leading to leakage under pressure. This anatomical logic shifts the focus of rehabilitation from the internal sensation of lifting the pelvic floor to the external mechanical action of controlling the femur, thigh bone, within the hip socket. For the older adult, this shift is revolutionary. It moves the practice away from abstract, often frustrating attempts to find the pelvic muscles toward tangible, visible movements like squatting, lunging, and bridging, which provide immediate feedback and carry over directly to the mechanics of walking and stair climbing. The science of intra-abdominal pressure IAP regulation is the next pillar of our non-Kegel approach. In a healthy system, when we inhale, the diaphragm descends, pushing the abdominal contents downward. To accommodate this pressure, the pelvic floor must eccentrically lengthen, it must yield. Upon exhalation, the diaphragm ascends, and the pelvic floor naturally recoils and lifts. This piston mechanism is the heartbeat of core stability. However, years of poor posture, shallow chest breathing, and chronic sitting often disrupt this rhythm in older adults. Many seniors exhibit paradoxical breathing, where they suck in their stomach upon inhalation, driving pressure upwards and preventing the natural descent of the diaphragm, or they bear down incorrectly, placing chronic strain on the pelvic ligaments. Exercises that fail to integrate proper breathing mechanics are destined to fail in resolving incontinence because they do not address the pressure management system. The exercises we will implement are designed to retrain this piston action, ensuring that the pelvic floor is strong enough to withstand the downward pressure of a sneeze or a heavy lift, but pliable enough to relax for proper voiding. This is a crucial distinction. We are not just building strength, we are building coordination and timing. A strong muscle that fires half a second too late is useless against the sudden burst of pressure from a cough. We must also address the impact of spinal alignment on pelvic floor function. As we age, there is a tendency toward thoracic kyphosis, rounding of the upper back, and a loss of lumbar lordosis, flattening of the lower back, or conversely, an excessive anterior pelvic tilt. These postural deviations alter the orientation of the pelvis, placing the bladder and urethra in a compromised position. When the pelvis is tucked under in a posterior tilt, common in those who sit for long periods, the pelvic floor muscles are shortened and inhibited. Conversely, an excessive anterior tilt can stretch the pelvic floor to its limit, reducing its ability to generate force. The exercises selected for this protocol are not merely strengthening movements. They are corrective exercises designed to restore a neutral pelvic alignment. By restoring the neutral position of the pelvis, we place the pelvic floor muscles at their optimal length-tension relationship, allowing them to generate the maximum amount of force with the least amount of effort. This concept of length tension is fundamental in exercise physiology. A muscle generates the most force when it is at its resting length, not when it is fully shortened or fully stretched. By realigning the skeleton through glute and core strengthening, we passively improve the function of the pelvic floor without a single direct Kegel contraction. The transition from a sedentary lifestyle to one of active pelvic health must be gradual and scientifically grounded, especially for the senior demographic where joint integrity and balance are valid concerns. The 5 exercises selected for this protocol are chosen based on their ability to recruit the global muscle systems that co-activate the pelvic floor. We are looking for high-yield movements that offer the biggest bang for the buck. For instance, the gluteal muscles are the powerhouse of the body. Weak glutes force the pelvic floor to overcompensate for stability, leading to fatigue and eventual failure, leakage. By strengthening the glutes, we offload the pelvic floor, allowing it to return to its primary role of sphincter control and organ support, rather than acting as a primary stabilizer of the hip. This is the principle of load sharing. In a dysfunctional body, the pelvic floor is often doing the job of the glutes, the deep abdominals, and the adductors. By rehabilitating these surrounding giants, we relieve the burden on the pelvic floor, often resulting in an immediate improvement in incontinence symptoms. It is also important to understand the neurological aspect of this training. The brain does not think in terms of individual muscles, it thinks in terms of movement patterns. When you walk, your brain does not send a separate signal to your pelvic floor to contract. It sends a signal to walk, and the pelvic floor fires reflexively as part of that pattern. Over time, due to pain, injury, or inactivity, this reflex loop can become dormant or delayed. The non-Kegel exercises focus on neuromuscular re-education. We are essentially reminding the brain that the pelvic floor is part of the hip extension mechanism, part of the squat pattern, and part of the core stability system. Through repetition of these compound movements, we re-establish the neural pathways that ensure the pelvic floor activates automatically before the bladder pressure rises. This is the difference between conscious cramping, Kegels, and subconscious function, life. For an older adult, the goal is not to have to think about their bladder every time they laugh or lift a grandchild. The goal is automaticity, and that can only be achieved by training the pelvic floor in the context of whole-body movement. Therefore, the roadmap for preventing urinary incontinence lies in a holistic reconstruction of the core canister. We must move away from the microscopic focus on the urethra and zoom out to look at the macroscopic function of the human chassis. We will engage the breath to mobilize the diaphragm. We will ignite the glutes to stabilize the sacrum. We will activate the adductors to secure the pubic symphysis. And we will integrate the deep abdominals to manage internal pressure. This approach respects the intricate engineering of the human body and offers a sustainable, long-term solution that goes beyond the temporary and often ineffective practice of isolation exercises. As we prepare to delve into the specific mechanics of the first set of exercises, it is vital to retain this foundational knowledge. We are building a house, not just fixing a leak. The pelvic floor is the foundation, but the walls, the hips and core, and the roof, the diaphragm, must be equally strong for the structure to stand. Transitioning from the anatomical substructure to the practical application of kinesiology, we initiate the rehabilitative process by addressing the most fundamental movement pattern of human existence, the squat. However, within the context of pelvic floor restoration for the older adult, we are not referring to the weighted barbell squat of the athletic world, but rather the functional mechanics of the sit-to-stand maneuver, which we will term the functional pelvic squat. This movement is the primary diagnostic and therapeutic tool for incontinence because it directly challenges the pelvic floor's ability to manage intra-abdominal pressure under gravity. When an individual descends into a squat or lowers themselves into a chair, the ischial tuberosities, commonly known as the sit bones, must mechanically separate. As the hips flex and the femurs rotate internally in the socket to accommodate the depth of the seat, the pelvis naturally widens at the bottom. This mechanical widening forces the levator ani muscles to undergo an eccentric contraction. Eccentric muscle action, often described as lengthening under tension, is physically more demanding and biologically more significant for strengthening connective tissue than the shortening, concentric phase. For decades, seniors have been taught to squeeze their pelvic floor to strengthen it. Yet the inability to eccentrically lengthen is often the root cause of dysfunction. If the pelvic floor is rigid and cannot stretch as the sit bones widen, the pressure generated by the descent has nowhere to be absorbed, leading to stress on the bladder neck. Therefore, the first pillar of our protocol involves the assisted box squat, performed with a specific focus on the release and engage rhythm. The objective here is to retrain the brain to allow the pelvic floor to relax and lengthen during the descent. As the patient stands before a chair, feet shoulder-width apart to optimize the stability of the sacral base, they initiate the movement by hinging at the hips, not by bending the knees. This distinction is vital. Knee-dominant movement loads the quadriceps and shears the knee joint, whereas hip-dominant movement recruits the gluteus maximus. As the hips travel backward and down, the senior must visualize the space between their sit bones expanding, effectively opening the pelvic floor. This visualization aligns with the physiological reality of the pelvic outlet widening. At the point of contact with the chair, the pelvic floor is at its maximum length. The critical moment occurs during the transition from sitting to standing. Instead of jerking the body upward using momentum or pulling with the lower back, the individual is instructed to drive the heels into the ground and engage the gluteal muscles. It is at this precise moment of gluteal activation that the pelvic floor undergoes a reflex concentric contraction. The lift of the pelvic floor is a secondary reaction to the powerful extension of the hips. By focusing on the power from the floor through the heels and glutes, the senior achieves a stronger, more functional pelvic contraction than could ever be achieved by a voluntary Kegel in isolation. This exercise creates a functional pump, stretching the floor on the way down and contracting it on the way up, restoring the natural viscoelastic properties of the muscle tissue. Following the vertical integration of the squat, we must address the lateral stability of the pelvis through the glute bridge with adductor coactivation. This second exercise is specifically designed to target the obturator internus and the adductor magnus, the muscles previously identified as key stabilizers of the pelvic bowl. The supine position, lying on the back, is strategic. It removes the variable of gravity acting vertically on the viscera, allowing the prolapsed or weakened tissues to return to a neutral position, thereby reducing the heaviness many seniors feel. In this unloaded state, we can isolate the muscle recruitment patterns without the risk of leakage that standing might provoke. The senior lies with knees bent and feet flat on the floor, but the critical addition is a softball or yoga block placed between the knees. This prop is the catalyst for the co-contraction phenomenon. The instruction is to gently squeeze the object with the knees, engaging the adductors, while simultaneously pressing the feet down to lift the hips toward the ceiling. The science behind this combination is profound. The adductor muscles attach to the pubic rami, the bony structures at the front of the pelvis. When the adductors fire, they create a shear force across the pubic symphysis that stabilizes the anterior pelvis. Simultaneously, the extension of the hips activates the gluteus maximus, which pulls on the sacrotuberous ligament. This ligamentous tension creates a stable anchor for the pelvic floor muscles to pull against. Without this anchor, the pelvic floor is like a rope pulling on a loose post. It cannot generate effective tension. By squeezing the block, front stability, and lifting the hips, back stability, we create a force closure mechanism that rigidly locks the pelvis, allowing the pelvic floor to contract maximally with minimal conscious effort. This exercise essentially tricks the pelvic floor into firing by creating an environment where it is biomechanically necessary for it to do so. For the aging population, this also serves a dual purpose of strengthening the lower back and improving circulation to the lower extremities. The emphasis must be placed on the quality of the squeeze and the height of the bridge, ensuring the lumbar spine does not hyperextend, which would indicate a loss of core control and a shift of tension away from the glutes and into the spinal erectors. The third exercise in our sequence addresses the posterior chain in a standing position, introducing the concept of the hip hinge, or the wall-supported deadlift pattern. While the squat focuses on knee and hip flexion, the hinge focuses almost exclusively on hip flexion with a static knee position, placing a tremendous demand on the hamstrings and the deep hip rotators. The relevance of the hamstrings to incontinence is often overlooked, yet they are anatomically continuous with the sacrotuberous ligament, which, as previously noted, interdigitates with the pelvic floor fascia. Tight, short hamstrings, a chronic condition in the elderly due to prolonged sitting, pull the pelvis into a posterior tilt, flattening the lumbar curve and inhibiting the natural shock-absorbing curve of the spine. Conversely, over-lengthened, weak hamstrings destabilize the knee and pelvis. The wall-supported hip hinge is designed to lengthen the hamstrings under load, which pulls on the ischial tuberosities and stimulates the posterior aspect of the pelvic floor. To execute this, the senior stands a few inches away from a wall, facing away from it. The movement involves pushing the buttocks backward until they make contact with the wall, while keeping the spine perfectly straight and the shins vertical. This reaching back action forces the center of gravity to shift into the heels, instantly engaging the posterior chain. As the hips hinge back, the pelvic floor once again undergoes eccentric lengthening, but in a different vector than the squat. In the hinge, the widening is more focused on the anterior-posterior axis. The return to the standing position is powered by a snap of the hips forward, driven by the glutes. This exercise re-educates the feed-forward mechanism of the core. In a healthy body, the core muscles, including the pelvic floor, should fire before movement occurs to stabilize the spine. By using the wall as a tactile cue, the senior receives immediate feedback on where their body is in space, proprioception. If they simply bend over at the waist, they won't touch the wall correctly. They must hinge. This distinction is crucial for protecting the lower back. Furthermore, this movement pattern mimics the action of picking an object off a table or leaning over a sink, activities where intra-abdominal pressure often spikes and causes leakage. By training the pelvic floor to remain engaged during a hinge, we are directly essentially leak-proofing these daily activities. The breath control here is paramount. Inhale to hinge back, lengthening the floor. Exhale to drive hips forward, contracting the floor. This synchronization of breath and movement reinforces the piston mechanism of the diaphragm and pelvic floor, ensuring that pressure is managed dynamically. In analyzing these first three movements, the squat, the bridge, and the hinge, we observe a common thread: the imperative of gluteal function. It cannot be overstated that gluteal amnesia, or the inhibition of the glute muscles, is the primary enemy of pelvic health in seniors. When the glutes are dormant, the burden of stability shifts to the lower back and the pelvic floor. The pelvic floor, which is a relatively small muscle group designed for sphincter control and organ support, is ill-equipped to act as a primary hip stabilizer. When it is forced to do so, it becomes hypertonic and fatigued, leading to the urgency and frequency symptoms often mistaken for a bladder infection or prostate issue. By waking up the glutes through these 3 exercises, we are essentially delegating the heavy lifting back to the body's strongest muscles, allowing the pelvic floor to relax and function normally. Moreover, these exercises stimulate the production of synovial fluid in the hip joints and increase blood flow to the pelvic basin. Ischemia, or lack of blood flow, contributes to tissue degradation and nerve dysfunction. The pudendal nerve, which innervates the pelvic floor and sphincters, weaves through the complex musculature of the deep hip. Tight, frozen hips can entrap or compress branches of this nerve, leading to altered sensation and poor motor control of the bladder. The dynamic nature of the squat, bridge, and hinge mobilizes the soft tissues surrounding the pudendal nerve, potentially relieving compression and improving the neural signal from the brain to the bladder. This neuromechanical perspective is what separates a therapeutic movement protocol from a simple fitness routine. We are not just burning calories. We are flossing the nerves and hydrating the facial matrix that supports the pelvic organs. As we master these sagittal plane movements that occur forward and backward, we prepare the body for the complexity of multiplanar movement. The human body does not only move in straight lines. It twists, turns, and stabilizes against lateral forces. The pelvic floor is arranged in a multidirectional web to handle these forces. Therefore, the subsequent exercises in our protocol must address rotation and lateral stability to fully bulletproof the pelvic girdle against the unpredictable demands of life, such as stumbling, turning quickly, or carrying uneven loads. The foundation has been laid with the squat, bridge, and hinge. Now we must build the lateral walls of our core structure to ensure complete containment and continence. This progression ensures that safety is prioritized, starting with stable, symmetrical movements before introducing the instability of asymmetrical exercises, making it an ideal progression for the senior population where fall risk is a valid consideration. Having established the foundational strength of the posterior chain through sagittal plane movements, we must now advance into the complexities of lateral stability and rotational control, domains where the true functional capacity of the pelvic floor is tested. The human pelvis is not a static basin but a dynamic ring of force transmission that must absorb impact from the ground while simultaneously stabilizing the torso during locomotion. The majority of falls and instances of stress incontinence in the elderly occur not when standing still, but during transitional movements involving rotation or lateral weight shifting, such as turning to reach a shelf or stepping out of a bathtub. Therefore, the 4th exercise in our protocol, the sideline clamshell with a specific focus on the obturator internus, targets the crucial lateral wall of the pelvic container. The obturator internus is a fan-shaped muscle that originates from the internal surface of the obturator membrane, literally lining the inside walls of the true pelvis, and exits the pelvis to attach to the femur. Its fascia, the arcus tendineus levator ani, serves as the direct attachment point for the iliococcygeus muscle, a major component of the pelvic floor. This anatomical fact cannot be overstated. The pelvic floor muscles are physically suspended from the fascia of the hip rotator muscles. Consequently, if the obturator internus is weak or dysfunctional, the hammock of the pelvic floor sags because its anchor points are unstable. The execution of the clamshell is often performed incorrectly in general fitness settings, reducing it to a superficial hip exercise. For pelvic floor rehabilitation, precision is paramount. The senior lies on their side, knees bent at a 90-degree angle, with the spine in a neutral alignment, meaning the waist is slightly lifted off the floor to maintain the natural lumbar curve. The movement involves lifting the top knee while keeping the feet in contact, resembling the opening of a clam. However, the critical internal cue is not merely to lift the knee, but to rotate the thigh bone deep within the hip socket. We are targeting the deep external rotation that cinches the lateral pelvic wall. By activating the obturator internus through this rotation, we create a lateral tension across the pelvic floor, effectively tightening the hammock from the sides. This lateral tension is essential for urethral closure pressure. During the exercise, the senior must ensure that the pelvis does not roll backward. The hips must remain stacked vertically like plates. This constraint forces the deep rotators to do the work rather than the larger, superficial muscles compensating. As the leg opens, the pelvic floor is reflexively drawn taut, providing a lift sensation that is mechanically induced rather than consciously forced. This trains the pelvic floor to maintain tension during leg movements, a skill directly transferable to the act of getting in and out of a car or bed, moments notoriously linked to leakage. The fifth and final exercise, the contralateral limb extension, commonly known as the bird dog or a modified wall plank variation for those unable to kneel, represents the pinnacle of core coordination. This exercise integrates the pelvic floor into the body's diagonal myofascial slings, specifically the posterior oblique sling, connecting the latissimus dorsi of one side to the gluteus maximus of the opposite side, and the anterior oblique sling, connecting the external oblique to the opposite adductor. These diagonal slings form an X pattern across the front and back of the torso, with the pelvic floor situated at the exact center of the X. When we walk, run, or carry groceries, these slings transfer force between the upper and lower body. The bird dog involves extending the opposite arm and leg simultaneously while maintaining a rigid, tabletop torso. This action forces the body to stabilize against rotational forces. Gravity wants to twist the spine, and the core muscles must fight to prevent this twist. In this anti-rotational effort, the pelvic floor acts as the bottom of the pressure canister, modulating internal pressure to stabilize the spine. If the pelvic floor is weak, the canister leaks pressure, and the spine becomes unstable. By performing the bird dog, we force the nervous system to recruit the pelvic floor as a stabilizer in coordination with the diaphragm and the abdominal wall. It is a cognitive challenge as much as a physical one. The senior must focus on reaching long rather than lifting high, stretching the spine and limbs in opposite directions. This axial elongation creates space in the vertebral column and decompresses the pelvic contents. Furthermore, the reciprocal nature of the movement, left arm, right leg, mimics the neurological patterning of walking. By strengthening this pattern on the floor or against a wall, we are directly upgrading the neural software for walking. A more stable gait reduces the erratic impact forces that jar the bladder, thereby reducing the urgency and frequency of urination. This exercise completes the circle of rehabilitation, from isolation to integration, from static to dynamic, and from simple to complex. However, mechanical restoration of the pelvic girdle is only one half of the equation. The biochemical and systemic environment in which these muscles operate is equally critical for the aging adult. We must briefly address the often overlooked factors of hydration and bowel health, which act as silent saboteurs of pelvic floor therapy. A common defensive strategy among seniors with incontinence is fluid restriction, drinking less water to reduce the need to urinate. This is a physiological fallacy. Concentrated urine is highly acidic and acts as a direct irritant to the lining of the bladder, the detrusor muscle. This irritation triggers bladder spasms, leading to urge incontinence, the sudden, uncontrollable need to void. Therefore, dehydration paradoxically increases the frequency and urgency of urination. A successful rehabilitation protocol must include the gradual reintroduction of adequate hydration to dilute the urine and soothe the bladder lining. This must be coupled with fiber intake to prevent constipation. The rectum and the bladder share a tight anatomical space. A rectum distended with impacted stool physically compresses the bladder and urethra, reducing bladder capacity and interfering with the nerve signals that control voiding. Chronic straining to defecate also places catastrophic downward pressure on the pelvic floor, stretching the pudendal nerve and undoing the strengthening benefits of the exercises. Thus, pelvic health is synonymous with bowel regularity. Furthermore, we must consider the psychological and neurological component of incontinence. The fear-tension cycle. The anxiety surrounding potential leakage often causes seniors to chronically hold tension in their abdominal and pelvic muscles, creating a state of hypertonicity. As discussed in Part 1, a tight muscle is a weak muscle. This chronic guarding creates a rigid pelvic floor that cannot absorb shock. The exercises provided, the squat, bridge, hinge, clamshell, and bird dog, are rhythmic and breath-centric. They encourage the dissipation of held tension. By focusing on the mechanics of the movement rather than the fear of the bladder, we downregulate the sympathetic nervous system, fight or flight, and engage the parasympathetic system, rest and digest. This shift is crucial because bladder emptying is a parasympathetic event. Storage is sympathetic. Balancing the autonomic nervous system through slow, controlled, mindful movement helps normalize the bladder storage and emptying reflexes. We are not just training muscles, we are calming the nerves that control those muscles. In conclusion, the paradigm shift from doing Kegels to training movement represents a fundamental evolution in how we approach geriatric pelvic health. The traditional Kegel model treats the pelvic floor as a solitary island, placing the burden of continence on a small group of muscles that were never designed to work in isolation. This approach is akin to trying to stabilize a wobbling bridge by tightening a single bolt while ignoring the crumbling pillars. It is destined to yield limited results. By contrast, the functional integration model acknowledges that the pelvic floor is a reactive, synergistic component of the entire human kinetic chain. It functions best when the hips are strong, the glutes are active, the spine is aligned, and the breath is free. The 5 exercises outlined, the functional squat, the adductor bridge, the wall hinge, the sideline clamshell, and the contralateral reach, build a structural support system around the pelvic organs. They recruit the giants of the muscular system to protect the vulnerable center. For the aging individual, this approach offers more than just dryness. It offers dignity and autonomy. The physical strength gained from these movements translates directly to independence, the ability to stand up from a chair without assistance, to walk confidently without fear of falling, and to engage in social activities without the constant anxiety of locating the nearest restroom. The science of neuroplasticity tells us that the brain is capable of learning new movement patterns until the very end of life. The pelvic floor is not lost simply because of age. It is merely deconditioned and disconnected from the rest of the body. Through consistent, intelligent practice of these non-Kegel exercises, we can reestablish that connection, revitalizing the pelvic floor not by squeezing it into submission, but by inviting it back into the dance of human movement. This is a journey of structural realignment and neuromuscular re-education, proving that the human body, when treated as an integrated whole, possesses a profound capacity for repair and resilience, regardless of age. The path to continence is not found in the isolation of a muscle, but in the strength of the whole.